It ain't about how hard you can hit. It's about how hard you can get hit and keep moving forward. For those of you that don't recognize this line, you'll find out about it very soon as you listen to my story here. The story starts in Vancouver, British Columbia, where I've been practicing dentistry for the last 16 years. And although dentistry is my day job, my most important job is taking care of this little guy. Most importantly, I want to be a role model to him. Because growing up, I had a role model too. You see, when I was little, my parents had a nickname for me. They called me Rocky. So naturally, I was drawn to this guy, Sylvester Stallone, Rocky Balboa. So I'm going to start the Rocky story right after he beats Apollo Creed finally at the end of Rocky 2. Rocky feels on top of the world. Now my story has a lot of parallels to this. You see, I had just finished a 5-unit implant-supported bridge on my patient. We had to do sinus lifting, we had to do bone grafting. It was a lot of work, and at the end of it, I felt like Rocky at the end of Rocky 2. And my patient, needless to say, was very happy, but not only did I have a happy patient, I had a fan in all of this. So everything felt great, just like for Rocky, everything felt great at the end of Rocky 2, but there was something coming his way. There was some trouble brewing, and in Rocky 3, it came in the form of Mr. T, who was Clubber Lang, who was a vicious opponent ready to take Rocky out. For me, it was this bridge that was on my patient's quadrant 2. Now, I had always been aware of this guarded prognosis bridge. We were watching it for many years, but one day she came in and it was very loose and she was in a lot of pain. So I said, how do we fix this? What do we got to do here? So I started planning. Now I was quite confident because we had done something quite similar on her right-hand side. So I said, patients don't want implants, they want teeth. And for her, if I put 3 implant-supported teeth in this area, I think we'd get a good result. Now, as you can see, her medical history was rather unremarkable, but she did have type 2 diabetes, controlled. We had done surgery for her before and everything was good. But I'm going to come back to this. Beware of type 2 diabetes, okay? Now, we did a further analysis of the bone and the sinus. And in her case, it became quite obvious she had not enough bone and too much sinus. So we'd have to sinus lift. Now, when you're sinus lifting, it's very important that when you're doing such an invasive procedure, you have an opening in your sinus, somewhere where inflammation and fluid can drain and oxygen can come in and kill off any anaerobes. And in this case, it's the maxillary ostium. We want it to be open. In her case, it was open. So, sinus lifting. What technique should I be using here? Do I do crestal lifting? Do I do lateral window? So, I took a look at this a little bit more carefully and I said to myself, well, how much residual bone height do I have? And as you can see, I have next to nothing. But more importantly, is this a narrow sinus or a wide sinus? Because when I looked at the research, there was a difference. With the wide sinus, which is what I have here, I've got about 16 millimeters width at the proposed implant apex. The research shows that getting medial wall engagement with any crestal technique is not always predictable. So you might not actually get very much bone generation. So it's for this reason that I chose to do a lateral window technique. Now for a lateral window technique, what we do is we make an osteotomy on the side and we go in with specialized curettes and lift the Schneiderian membrane out of the way and graft. To do this, we need specialized instruments because for those of you who've ever tried to lift the Schneiderian membrane, it's a wet piece of toilet paper, single ply, okay? So you need very specialized instruments that have very convex ends to it. But it's not only that. If I'm doing an invasive surgery like a lateral window, I need to look at other things, other possible minefields like blood supply. In the lateral window, we have the terminal branch of the posterior alveolar artery, which can sometimes be in the way of where our window is. And in her case, You can see it was about 12 millimeters from the crest because her alveolus had resorbed from not having teeth there for so many years. This didn't concern me too much, actually, because I felt I could make a window well below that. What bothered me more was this. She had a septum in her sinus, okay? So remember, we're trying to peel the Schneiderian membrane off the sinus floor, and guess what? If you have a needle sticking out like that, good luck not tearing that wet piece of toilet paper we talked about. So for this, I needed something very clever. So I thought I was being exceptionally clever by not limiting myself to just a lateral technique. I said, why don't we do a crestal technique as well? What we can do is approach it with a guided osteotomy near the vicinity of the septum and use hydraulic fluid to lift the Schneiderian membrane out of the way. Now, this was my plan. And when I went in for once, the plan worked perfectly. I went in like Rocky when he was fighting Clubber Lang in that first fight. He came out swinging. So lateral window was made, sinus was lifted. We grafted inside the sinus, we grafted the ridge as well. I even did a membrane stabilization there, and I sutured. I was so ecstatic. I was like, oh my God, I've really kind of leveled up in my surgical skills. And I had a meeting with my team shortly thereafter to talk about it. She came back day 11 here, and something just didn't look right with the healing. I was like, okay, well, usually it looks better than this at this stage. I felt around and I felt that yellow nodule. I'm like, maybe a little bit of fibrotic tissue. Patient wasn't in that much pain, or symptoms weren't too bad. A little bit of congestion in her sinus. So I followed up with her at the 25-day mark. 25 days, congestion in her sinus, worse. Swelling, still present. And now I'm seeing pus coming out of this area, okay? I'm thinking, okay, hopefully this is a superficial infection. I irrigated it, I tried to drain what I could, I put her on antibiotics again, and I followed up with her, okay? Everything's fine, she's great. 35 days post-op. So, what do? I go to Hawaii, okay? I'm chilling, I'm relaxing. 3 days into my trip in Hawaii, unbeknownst to me, she shows up back at the office, massive swelling, congestion, bad taste in her mouth, and she's in pain again. My colleagues saw her. They didn't know what to do. Put her on antibiotics again and booked her in with me as soon as I got back. As soon as I get back, I'm there thinking, geez, okay, this is not going away. I need to take my kid gloves off here and do something. So I numbed her up. I did an incision. I irrigated everything I could. And I put her on some Levaquin. And then at that point, I was like, I don't expect any sort of grafting or anything to work here. I'm gonna leave it in God's hands at this point. Luckily, she was symptom-free after this. And I waited 5 months, and I wanted to see what my scan would show. And this is what my scan showed. Bone graft resorption, congestion in the sinus, sealed ostium, okay? No way I'm putting implants in here, okay? I felt like Rocky at the end of that first fight, just leveled. So what did Rocky do? Rocky went to a friend. He needed help. He went to Apollo Creed to help train him for the rematch. So I went to our colleagues at ENT. I was fully expecting they would do a functional endoscopic sinus surgery to open up the ostium, clear everything out, and expected to be back at square one with my patient. Funny enough, they did none of that. What they did was they put her on a sinus rinse. And when I looked into this after, this is the first line of therapy in sinus infection. I had not done this. I thought antibiotics would do everything. That's second line of therapy. So they put her on a sinus rinse and monitored her for several months. And then I get this letter. Patient is cleared for implant placement. So now I know I got to get back in there and make this right. Okay? I first had to see this for myself. So I brought her in for a scan. Sure enough, the sinus is clear. We've actually got some bone and the ostium's clear. So I'm squaring up now for a second fight with Clubber. I planned this using computer-generated guide, 3 implants to be placed, and this is how my fight started the second time. Unlike the first time, I took a beating right off the bat. You see, this time I did not want to do a lateral window. I had more residual bone height. I thought I could do a crestal lift. I wanted to be conservative. She got an infection last time. I don't want to take that risk again. What I don't know about crestal, and what a lot of us should always be aware of, it's a blind technique. And sometimes the water doesn't always lift the way you want it to. See, there's different patterns to how the water lifts, and I got the horizontal spread pattern. So nothing was really lifting. So at this point, I had to go with lateral window again. So I did, and that's when things got even worse. So when I went lateral window, my buccal wall at 2.6 site completely blew out. I realized I had a crater at 2.7 site because we had such soft bone there. The area was inflamed and infected for so long. It's hard for bone to really mature and heal in those types of sites. And at this point, I really had to dig deep and say to myself, I cannot put this patient through more misery. Can I stabilize implants here? Yes or no? And when you have bone and the right implants, sometimes miracles are possible. And so that's what we did. We stabilized 3 implants. At the 2.6 site, all I had to grip was the palatal wall, that 2 or 3 millimeters that we had. I grafted. We got decent initial stability, not enough to put healing abutments on, but enough to leave in there, at least under the gingiva. And around my implant, I put some autogenous bone. Guess where I got that bone? From the lateral window. So I closed everything up. Now this time I'm being very meticulous. No chance, I want no chance of infection. So I'm using a native collagen membrane just because they reepithelialize faster. I'm using double layer closure technique to minimize chance of incision line opening. And I'm using only monofilament sutures. Again, reduces chance of wicking of bacteria. And then of course, the rest is really up to biology, Mother Nature. I mean, I've done all I can. Now I'm very nervous. I'm expecting some bad things to happen here again. Nothing. 1 week, 2 weeks, 3 weeks, even 4 weeks later, nothing happened. But I'm scared. I don't want to open that up and see what's under there. So I actually delayed the opening, the uncovering, for 11 months. So I waited a full 11 months. I was procrastinating. I didn't want to look under there. She was fine, no symptoms. She had her implants. But what she really wanted was teeth. So sooner or later, I had to go under there. So I uncovered it, and lo and behold, everything was stable. Bone around the implants, and all the implants were torque testing just fine up to 35 Newton centimeters. In fact, when I uncovered, you'll see I moved the keratinized tissue to the buccal to get a little more attached gingiva around my implants. And then we restored. There's the SCRC crowns that we placed. And there's the final x-ray. How does it feel to redeem yourself? I felt like I had knocked out Clubber Lang, finally. This is the 2-year follow-up. Everything's still stable. Here's a photo of the 2-year follow-up. Now, in this case, I felt like I got hit. I got hit a few times, but we kept finding a way to move forward. But one thing we should never forget is nobody got hit harder than my patient. She's the one who had to suffer through the infections, the multiple surgeries, the swellings, and the pain. And I credit her for allowing me to share this story to you. Thank you to Manek, Megamind, for putting this on, and thank you to the Bites Institute for all your mentorship and guiding me in this. Thank you.